difficulties when implementing. So, John Orsini is here, and if you want to know anything about the instruments, and if you want to learn research about it, John will be certainly the one to speak to. But what I will do is share with you what's happening after John left, and after people like John comes into the hospital and speaks about these instruments of various kinds. Those of you how many of you have been to Sweden? Probably you don't have that much of an understanding of our country, so let's begin there. Sometimes you just assume that everyone knows where you're from and you know how your system works, and then no one understands anything because you have different frames of reference. This is Europe, of course, and we are right here. And right there is Stockholm. And Stockholm is, and my colleague here is from Malmö, right here. So we're from different parts of the country. Our country has about 9 million inhabitants. That is a rather small country. All in all, in our country, we have, at every point in time, we have about 6,000 residents in training. And if you compare that to the American numbers, I think there are 118,000 residents in training every day of the year or something like that, if you look into the HCDME's sort of statistics. So we're quite small. But nevertheless, I would assume that the kind of problems we run into when you're restructuring postgraduate training is not very unique to us. I'm quite sure bits and pieces also resonates to you and where you're from. Let me begin just by showing you a little bit of where I'm from. This is the Karolinska University Hospital. Karolinska University Hospital came about 1940. It was the clinical teaching hospital of Karolinska Institutet. So on the one side of the road you have Karolinska Institutet. You can't see it from here because this is the back side of the area. So on the one side you had Karolinska Institutet, the medical university. On the other side of the road you had the university hospital where all clinical training actually took place. But at the same time there was another hospital that was built back in the 70s, and this used to be called Huddinge University Hospital. But imagine that being in one city with 2 million inhabitants, affording to have 2 university hospitals competing. Duplication of services at the various sites, and in the end someone said that, look, this is not affordable any longer, we need to merge these 2 hospitals. And anyone involved in health economics and administration, you would know that it's not that simple. You just merge 2 hospitals and all of a sudden you get a much more efficient hospital. It's been a very, very long struggle to get these 2 hospitals to work together, and it still is that this is referred to as the Karolinska University Hospital, and this is still Huddinge, even though now it's like one big hospital. In my hospital, yes?
Do you merge it as one big general hospital?
Yeah, well, I mean, yes, yeah, but just mind your step, because people at Karolinska would disagree with you. A general hospital. Whoa. This is a highly specialized tertiary care kind of hospital. So, I'm pulling your leg. So what they did really was that if you had like the Department of Surgery here and Department of Surgery there, that they did the same kind of procedures. They just decided that we will have one Department of Surgery, and certain procedures we will do here, and certain procedures we will do at this other hospital. Even today, though, in pathology, for instance, you would have Site A and Site B and Site C and Site D, and they're all completely different, even though under one management structure. What is happening now? This hospital today has 550 residents in training at one point in time. So under my umbrella and under my director's umbrella, we have 550 residents and about 44 different residency directors. This is, I don't know about you guys in Malmö, but I would claim, maybe I'm wrong, but I would claim that we are the largest actor in Sweden in terms of number of residents. Yeah, you agree? I think that's actually true. I'm not always telling the truth, but I think that in that respect, that is true. What's happening now is something really interesting, and that's going to ruin the world of residency training, I would argue. That is that we are building a new hospital, the new Karolinska University Hospital. Right now, with the 550 residents in training, we have a problem to train people, let's say in internal medicine, because there are no general patients coming in. there are no sort of chronic diseases coming in. There are not many sort of regular patients because they go to other hospitals. So the kind of selection you will find here of patients sometimes does not resonate very well with the general population needs. And I'm quite sure that's the same thing in Malmö. You find it at other university hospitals as well. Right now, there's 1,600 beds. But from about a couple of years from now, there's going to be only 800 beds. And what do you do with a super specialized hospital that almost halves the number of inpatient beds over one night, basically, when the new hospital will open in 2016, 2017? This will indeed make it very, very difficult for us to continue to train residents at the hospital. Maybe you can do fellowships, maybe you can do different kind of subspecializations, but it's not going to be the place where you actually will do the general training for the first years of residency. In our country, and Stefan can probably tell you much more about this, but in our country, the way it works today is that we do have an undergraduate intake to the medical schools. So you normally start when you're 19, 20, 21, something like that. You go into 5 years and a half, which is the medical curriculum in a medical school. You come out with your MD degree, but you're not licensed to practice. You need your 21 months of internship, where you actually work as a junior doctor. And the rotations will be surgery, internal medicine, psychiatry, general medicine. That's the ones, right? Yeah, the four of them. Then, what happens is that you enter residency training. So you come to us. And for many people from America or for other parts of the world, the way our system is operated is very difficult to understand, because there is nothing like a match as you find in the US, that you apply to residency and then the hospitals offers the number of residency posts they have and they sort of match. Our system is much more decentralized, so you actually apply to the clinic where you would like to work. And normally you work as a junior doctor for like 6 months or 8 months before they will say, will you stay with us, or will we hire you as a resident or not? So it's a very, very decentralized system. Now, in all of this, for my colleagues in the US, what you tend to find is the whole idea about residency training as time-based. And I'm quite sure it's the same thing for you everywhere. It's a very time-based approach to training. That is the case in Sweden as well. So when you speak to someone, they will normally say residency takes, 5 years? Sometimes 6 years, but at least a minimum of 5 years. And when you think about rotations, they always speak about rotation about 5 months or 3 months or 6 months. It all depends on. But this is only partly true. And here we're getting closer to the topic today about workplace-based assessment. Because of what happens in our country, as well as in many other parts of the world, is that this whole notion about the teabag model, I think it was Hodges actually who coined that expression a couple of years ago, the whole notion about time as a proxy for quality is being challenged everywhere. And that is indeed true in our country as well. So, back in 2008 was a national reform in the kingdom, as I would say, Sweden. I'm not from the United Kingdom, I'm from the kingdom. But back in 2008, there was this national reform. And at that point, trying to formalize medical curricula. So each specialty out of the 58 or 59 now have their own national curricula. And I guess the whole idea, of course, is consistency. Because depending on where you've been trained, if you train as a general surgeon in a rural area somewhere or in a county hospital, the kind of patients you see, the kind of procedures you do varies a lot from if you train either in Malmö or at Karolinska or at other places. But by having a national curricula, you try to get a very consistent sort of training. So really you train a surgeon, and the surgeon's training should not depend on the hospital he or she actually works at. Now, here we go. All of a sudden, someone has been to a conference and heard about a new tool. They call it, let's say, assessment. and even simulations could be something they want to integrate to the curriculum. So what's happening is that we have the whole notion that we need to assess our residents. And the national data we have show clearly, in terms of the quality inspections they do, that generally speaking, most programs do very well apart from two things. There's no feedback into the programs, and there's a lack of structure in terms of how the rotations follow on each other. Variable D and E, if you go into dispute inspection, which is the national quality inspections. So indeed, there is a good argument that we need to bring in various kind of assessment instruments into the system. But the problem is, how easy fix is this actually to do? There is a lot to learn, and we had Jonas with us a couple of years ago when people still speak about that workshop in terms of how people really got aware of how different we rate quality. And it's always when you do these things, when you rate people, and you can see that even in a group like this with very senior people, you find almost a normal distribution in terms of what people think is quality or professionalism, whatever it is, when you look into a specific clinical encounter. Now, what I will argue today is that I'm afraid that what our experience at Karolinska is this. If you go to Ronald Heifert's work, he's a great professor at Kennedy School of Government at Harvard, and he makes a distinction between adaptive problems and technical problems. While the technical problems are the simple one, well, they don't need to be simple, but you know what the problem is, so you have to find a solution. The problem is defined. Sometimes it's very difficult to find a solution anyway, but at least you know what your problem is. Adaptive problems are slightly more complicated because sometimes you don't really know what your problem is, and even if you did, the solutions might be slightly more complex. And I would argue that when we look into the lack of assessment in our system, and when we look into the entire sort of world on how to fix the problem about assessment, because we know, as I said to you, with this data, it doesn't quite work, and there's very little feedback into the system. Still, the way our residency directors and the way many people think about it is much more as a technical problem. There is a lack of feedback. We do need to do something. It's a technical problem. But I would argue that that is not true. In our case, it's much, much more complex. It's much more of an adaptive problem, and I will speak about that in a minute. The same thing, if you go to Donald Schoen's work and you read about a reflective practitioner, and I guess that's been outdated these days and not many people speak about him. But again, what he really did, which I think is of great importance, is to make the distinction between problem setting and problem solving. You need to do your diagnosis. I mean, how can you treat someone unless you haven't defined what the medical problems actually are? So it's really the same thing. At our hospital, in terms of clinical assessment or assessment in general, problem solving seems to be where people go, and they tend to see the technical side of the problems rather than the adaptive side. And here we go. And I would be interested to hear your opinions about that. So how do we actually go in a system like ours, where you have strong faculty with very good research, and because Karolinska is number 11 on the world list in terms of clinical medicine and pharmacology, that is mainly due to all the papers published at the University Hospital. And at the University Hospital, you have a very strong culture about research, about performance, etc., etc. And I guess that's the case in many institutions. If you're at Karolinska, you are brilliant. It's a very strong, well, I'm not saying they are, and we are, but the notion of the institution. So the entrance into the system, the entrance into the hospital is very important. And I guess that when you accept your residents, they come in, they spend 6 and 8 months with us. That's a cultural screening. We'll see how good they are, and we'll see if they will be good colleagues, and we can work with them and their attitudes, etc., etc. And after 6 and 8 months, that is an extensive period of assessment of various kinds in terms of accepting someone into the system. But how do you actually, in a system like this, go from entrance into a formalized, not perhaps exit exams in terms of a summative way, but just bringing in also formative instruments during residency training. And not just saying that, Stefan, you're so good, this was just a good procedure, and then off you go. But it's a much more rigorous way to give feedback. And I'm just wondering, I mean, John, what would you say? I mean, you do these things all over, and do you disagree that assessment is sort of seen as a technical problem, or what would comments be on that?
No, I completely agree with you. I think you're right on target, and I think one of the big stumbling blocks for workplace-based assessment is one.
Oh, you want maybe you want? Well, thank you for coming, John.
No, I completely agree. I think that one of the main problems with workplace-based assessment is that people view it as technical, and in fact that folks have not figured out ways to use it and adapt it into their system so that it makes sense and so that it's readily used.
So when you look into all the systems you've been involved in, I mean, what you did in the UK, for instance, I mean, from your perspective, have you actually handled this? Because one thing is to do it, sort of the workshops and the training, and people come in and they learn the instruments and they translate the protocols and they validate the new sort of protocols, but to get it into the system.
Well, I think that's the real challenge. I mean, I think that's the real issue with workplace-based assessment. And so to the degree that I've been involved in that, the solutions are really local. They really relate to the local faculty and what decisions they're going to make. And so I've engaged with some faculty around training processes that sort of got them involved in thinking about the people who were successful in implementing it and using that as a strategy for getting at this. The work of the Sternens, I think, comes to mind. But I think that's really where the challenge is.
The way we've been thinking about it is, let me go back here, is this. And when people start, lots of your work and a lot of the DOPS and the mini CEX and all these kind of instruments has been translated by colleagues in Malmö, and they're all available on the different web pages that you actually can download them from into Swedish. The problem is this, I would argue, again, it's a technical problem and culture is taken out of context, but we have this part. It's very, very important to do the connection between the national curriculum and the instruments. And I'm quite worried when I see that how many of these instruments have been exported and imported from one system to another system. Because at the end of the day, what you find in our country, as well as in other countries, is that when you assess someone, you have to assess someone against something. And that something is nothing that's elusive out there, it's something very specific. And in our case, there is a national curriculum. There is a national curriculum for each and one of the specialties. So that means that even though you do have lots of instruments out there, and even if you cannot sort of implement them, they have to be related back to the overall aims and objectives of the national curriculum. Now, what about the national curricula? The national curricula has been written in such a loose way, and it's so undefined and it's so unspecific, so it becomes much more of statements about quality in general. But it becomes very difficult to break it down and to operationalize it so you can actually measure it. So the really first step for us was to try to start to think about it much more in terms of technical problems, to train people to learn to use the instruments. Once you bring it back to your clinic, you will see that, well, it's not that easy because people don't want to get feedback and they are afraid of getting feedback, and for sure they cannot give feedback because they only want to say something very positive. But that was one set of problems. But the other set of problems, which is much more difficult to deal with to some degree, is the lack of the lack of coherence in the national curriculum. So I'm just wondering, in terms of how many of you here are using workplace-based assessment instruments of various kinds, any instrument you're working with? You do. How do you think about, the standards you measure it against? Do you think, are they sort of general instruments, or are they connected to a national curricula, you would say? Anyone want to share?
They are customized. Each specialty decides what to measure, when to measure, and with this all kind of a standard is the length of each specialty. But it's not quite standardized what are the outcomes at the end of the program.
Mm-hmm. It's the same.
It's the same.
The same. Yeah. Stefan, what you, I mean, from your perspective, you've seen this from a slightly different. Anything you want to make a comment on? No, you wait. Yeah. John, what would you say? I mean, in terms when you go around the world and you do the workshop and you speak about this, how much awareness would you say there is about the connection, the alignment with the curricula as such? Oops.
I think that's a huge problem. I think that one of the things that we do sometimes is we create the forms, give the forms that will be used as part of the assessment, but then allow the faculty to actually change the forms so that ultimately it aligns appropriately with what it is they want to teach. So I think you've again touched on a really important point.
Yeah. Anyone else? Any questions? Anyone else who want to, thank you, who want to sort of share something in terms of the curriculum issues? Right then, I think that, so from our perspective, there are two things into this that goes into it. The number one thing would, of course, be to understand the complexity and really try to work into the culture within the institution. And that's very, very difficult. And we had something, in a hospital big like ours, and I'm quite sure you have the same in your hospitals, we have certain specialties that are more interested than other specialties in training. And anesthesiology has always been a very strong research sort of base in the hospital. It's always also been a very educational-friendly environment. So they're always progressive and they want to introduce these various kind of instruments. But in the day, when you even try to do any of your instruments, comments comes out from residents, we didn't get any feedback. Even we have the instrument, we didn't get any feedback. And faculty says, well, look, we've been giving you tons of feedback. No, you haven't, because of misconception about how do you, what is proper feedback, and how do you give feedback, what you understand to be feedback, and and all those things. And I think that Gans comes back to the whole notion that we're not used to think about feedback, either giving, either receiving, even if you do have these kind of problems. So I think that a very big challenge for us running the hospital in terms of residency training has been, A, to put it on the agenda, B, start to train people about using these particular instruments, and also start to make a big survey within the hospital about how people perceive what feedback actually is. So you open up sort of the Pandora's box in terms of trying to get people to start to think actively about these various things. In the end, I mean, it becomes a big issue within the hospital because we disagree about quality, and we're so used to see it, we know it when we see it, not it goes sort of back to an instrument. But the other thing into this is the whole issue about the national curricula. I would say that to some degree it's useless because, A, the national curricula for each one of the specialties are very much an historical document in terms of what a senior consultant should be able to do up on retirement. That is not what you actually can do after 5 years of training. This is what you should be able to master after 5 years of training. Rather, the national curriculum represents a totally different way to think about it. And even if it is an X-ray of what a senior consultant should be able to do when he or she retires, still, it's not precise enough. So you can connect it back to very many instruments used, either formative or summative. So our story really is the cultural issue working in the hospital and trying to avoid just see the technical problem. Because it started off, I mean, we made the same kind of journey trying to see it as a technical problem, but in the end we understand it's much more complicated when you want to put it into work. But the second thing into this is the entire work you do need to do with your national curricula to have a standard to which you relate these very different kind of instruments. So I think that that's what I'd like to share with you in terms of where we are, and I would like to open it up for a dialogue, because I don't think that we are unique in any way. I'm quite sure that this is what you see in many hospitals, and I think that, yeah. Stefan, here we go.
I'd like to make a comment at this stage, and I think one of the big reasons for the problem that you're describing is that we haven't been able to establish a continuum when it comes to medical education of the physician, from basic to specialist training to CPD, and therefore we sort of use different models in different situations. It is very clear from the government point of view and the higher education departments at that level that for undergraduate education, they want to have rather general sort of guidance for the diplomas, and leave it for the universities to be able to interpret that by themselves. But they must demonstrate how they reach them. When it comes to the residency, this is not clear. It's a mixture of some sort of general outcomes and some specialized levels. At some levels, it's very general. Other levels, it's very specified. And I think that causes a lot of confusion. We should really try to learn from the different phases and try to agree upon one way of doing it. But personally, I believe more in having more general sort of guidance and outcomes, and then expect that the educating institution should be able to interpret what that means, rather than pointing at each exact millimeter.
Any other comments on this?
I have a question. Oh, sure. You will say that your residency programs are hospital-based or university-based. That will be one question. And the second is, the residents are trained just in one hospital, the entire program?
Oh, wow. That's the $10,000 question, I think. I didn't even think about that. Yes, you're right. I think Stefan would be the one to really answer in terms of if it's a university problem or a hospital problem. I have my opinion, but since you why don't you tell them what you've done, Stefan?
But I interpret your question asking who is responsible for the residency, and that's the hospital and not the university.
Yeah, but that's true.
Yes.
Yeah,
but that's
in terms
the
of
easy question.
In terms of the blame culture, I mean, why don't you tell them what you've done? That could be interesting for everyone to know, because you're very involved in this.
Well, what I have done is related to what Professor Harden talked about earlier on, that we must consider also in our country that why do we have such long education processes? Actually, residency usually comes in the broader specialities also to you becoming a subspecialist. It means to add another 2 and 3 years. It means something like 15 years to be a specialist. And there's no reason for that, because you will never finish your education. It's just some transparent competencies that can be used for employment and for further training. So on the task of the Swedish government, I suggested a completely new undergraduate education stage of 6 years that would lead to a clear competence, and that would be the ground for licensing. And we will see what will happen with that. Then your other question about if they do it in one hospital or different hospital, that depends on the setting. But in most cases, several hospitals in the region are involved.
But it's also, I mean, in the old days, I mean, as you can see on this picture, I mean, I guess that in any country where you have this kind of stages as you do, but here you have a set of cultures that goes into different assessment culture, etc. Many people involved. Same thing here and same thing here. And in our country, it's a very clear divide between university, which is here, and then from here on, you are in the hospital setting. But before I'm gonna let you in a minute. But the bottom line is that in the old days, which is not now, but in the old days, it used to be. I would say we can disagree on that, but I would say that mainly, generally speaking, residents were hired at a clinic because they want to have new recruitment coming in. So you brought someone into your clinic, and the idea was that that person should stay in the clinic. So you actually don't export someone. It's a significant investment to get the resident on board. What's happening now in the kingdom is that healthcare is getting private. You see in primary care, you have about 75% of the primary care centers in Stockholm is now private. Oh, what about assessment, and what about culture, and what about money and productivity? Have you heard? And all of a sudden, you have ENT. Your day surgery is now private clinics. If you go into ob-gynecology, You have lots of day clinics, private clinics, orthopedic surgery. They do a lot of day procedures in private clinics. And if you see this picture of our university hospital, the new university hospital, is a very big hospital in one way, but it's a very small hospital because there's so many procedures these days you cannot do in our hospital because you have to go to another hospital. And sometimes in ENT, they will be dependent on the private practitioners, and certainly for general medicine. So think about the number of stakeholders involved in training and assessing people and everything that goes into it. I mean, it becomes hugely complex. So I think we have a good case to say that this is not a technical problem. This is indeed a very adaptive problem. Sorry, you had a question.
I was going to ask you about the length of the program. It says there 5 years. It applies to every residency, or it varies from residency from specialty to specialty?
In our country, what you do is that during your internship, you make up your mind whether or not what kind of doctor you may want to become, and then you start to work extra as a junior doctor on the kind of clinics. You're trying to get closer to the clinic. Sometimes you get recruited. Sometimes you know, can I work with you for a while? And after about 6 to 8 months, they will know if they like you. And you will know if you like them and fit into the system, and that's sort of how recruitment actually goes. And at this point in time, I am the quality inspector for one of the counties in our country. And it's interesting because the whole issue about dimensions of how big should a specialty actually become, there's zero correlation between the size of the specialty and the needs in society. And I remember I was in Brazil not that long time ago, and a big issue here in Latin and Central America is the dimension of the specialties and who should make decisions about the size of the specialties. And it's certainly the same thing here, that it probably gets a little bit away from the assessment instrument, but again, the dimension, who make the decisions about how big a specialty should be. It all depends on how strong people you have in your specialty at your hospital in terms of number of residents you actually get. You would, yes?
Just a comment. Where, as Stefan was describing there, where do you actually rotate those interns and residents into the primary care units that you were starting to describe? You put them you have a connection with them, with the primary health private centers. That is a community, and so do you have a network of that? Could you please?
So the way it works in the same thing in the county where I am the quality inspector, what happens is that general medicine would have all those. They're very decentralized, and at certain healthcare centers you only have 1 or 2 residents, and here even assessment becomes a very critical issue, because at the hospital you would see your colleagues and you would see how someone actually does at the wards and the outpatients, etc. But in a primary care unit where you have very many individual consultancies with patients, assessment becomes even more important. The way it works is that there is a sort of a pot of money, and that pot of money, or so the amount of money every year goes into residency in general practice. So you have like central government money, and then that is then given out to the different primary care centers where they actually do the training. So the private providers do not pay to have residents. It's central government money, but then in order for you, if you're a private practitioner, to get a resident, you need to apply and comply with certain quality standards. And I'm not sure what you would say about that, Stefan. My understanding is that the specialty, at least in Stockholm, that has the higher standards of any would be general practice. They have a really rigorous system for anyone to accept a resident. If you look into this other county where I'm working right now, it's the same story. Many private clinics, but the highest quality standards ever is in general medicine. Any other questions?
Yes. Who says that the resident is ready for practice? The same hospital who trained him and was financed by the government, or an external body like a board or something?
John, just close your ears now, will you? The one, well, I'm looking a little bit scared here at Stefan. How am I going to get out of this? Officially, it's the head of the clinic. Officially, it's... I don't really want to say something strange about our beautiful country, and we have sort of wonderful mortality, low mortality, and all those other numbers. But at the end of the day, it's a time-based system. It's moving towards an outcome competence-based system. But what they tend to forget is to bring in assessment into that equation, which some people might say is a problem. But the bottom line is today that the quality assurance would be for the head of the clinic and for the senior consultants in that clinic. So there will be some kind of, I guess it varies from clinic to clinic, but it's a decentralized decision. And once the head of clinic signs off that you are done after your 5 years and you've done all your rotation, then you can apply to the National Board of Health and Welfare to get your certificate as a specialist. And there's no objective testing in between. There are no sort of exams you need to take. It's just that the head of clinic actually signs you off. Yeah.
I think you're very polite to your country, Jonas. But I think we can be much more critical and answer to your question that nobody knows. It's just assumptions. And when we are now striving to change the system, we are working, as always, against some sort of ignorance, because the ones who are working with these things in the residency period, they don't have the knowledge from university and from undergraduate about how we should think about things. They have a belief that you can analyze the process, and where the process contains different courses or some time frames, then you assume that the individual has the competency. We are striving and trying very hard to change that into a system where you, by different ways, make sure that the resident has demonstrated the competence expected from a specialist. But we still have a long way to go there.
But what you tend to see, and I'm quite sure the same in many other university hospitals, what you tend to see, I mean, some very positive news here, I would say, in terms of assessment. In the old days, when so many procedures you could do right on a patient, see one, do one, etc. Today, in my hospital, there are so many procedures where you need to be certified in a simulator before you even can touch a patient. So you have all those different radiological procedures, you have sort of all the OB-GYN procedures, you have a number of other procedures that you first do on a simulator. And then unless you objectively can pass the test, then you're not allowed to proceed to work on a patient. So I think that is really some kind of, but again, that kind of feedback and that kind of testing becomes a very technical testing about very specific procedures. So it's not, I'm not saying it's a technical problem, but if you see what I mean, it's very concrete skill or a very concrete procedure where you actually can demonstrate your competency on a simulator. So here I think that Sweden has gained quite a lot of progress. And you see that in this meeting as well. I mean, it's a strong push for, then we know that Jeff Norman has ideas about this in terms of expensive and non-expensive simulators, etc. But I think that's also where we're heading. Any other questions? Yes, we have a question in the back.
Si mal no entendí, la decisión de que ingrese a la residencia.
Oh, hang on. Yes, please proceed.
Si mal entendí o no sé si entendí bien, para que el estudiante sea aceptado a la residencia, de alguna manera se toma la decisión en consenso después de estos 8 meses que ha sido observado por los diferentes médicos pertenecientes al servicio y también por el jefe del hospital.
Yeah. That's exactly how it works.
Otra pregunta que tengo también es, ¿qué sucede con aquellos que no son aceptados a la residencia?
They go somewhere else.
¿A otro hospital o a otra área?
But also what you tend to find is that you may not get into your own specialty. You might then choose another specialty, and we always know that there are too few psychiatrists. There are too few for general practitioners. There are too few people in geriatrics, for instance. So certain specialties are oversubscribed, should I say, and then you have the constant sort of undersubscribed specialties as well. So it's not that you will end up not becoming a specialist if you really want to become a specialist, but maybe not in the specialty of your first choice.
aprovechando que tengo el micrófono, quisiera hacerle otra pregunta más para saber si entendí bien. Los médicos, la medicina general se lleva a cabo entonces como parte de lo que el gobierno ofrece a su población y la residencia se hace en hospitales privados.
Yeah, when it depends on where you live in the country, but yes, I mean, private practice in our country, in the region where I live, is mainly private these days, yes, and that's also, not for all regions, but for a number of regions, yes. Let me just finish. I know that I'm standing in between you and the lunch, but I mean, I think this is a fascinating story. It all started when John came a couple of years ago, and we all sort of started, the way we thought about it was that this is a technical problem. It's a technical problem, and we need to train people properly in the instruments, and once we sort of start to translate these instruments. And then gradually you see just how complex it becomes. You see how this instrument doesn't quite fit into the culture at the hospital, how people feel very uncomfortable, particularly unless you just tick in the middle of the box, and how they actually can use the instruments. You see the differences that so many stakeholders are involved in assessment. The whole issue about the progression of training and the different kind of culture that comes into it. You see the connection back to the national curriculum. So really, our story would be, if there's something I want you to bring here, that it all started off as a very well-defined, we thought, technical problem. It's just about training, really, unfolds to become complicated. But I have to say that in the end, I'm very positive. There is now a very strong push among residency directors to start to think about assessment, formative mainly, but also summative. But it will take years to change that culture. But you see, we just had a national leadership one-year program for residency director in our country. And if you look into the exams, the essays they write, about 80% of the exams, the papers they write, the thesis they write, is about assessment. So you see now there's a strong push among residency directors to start to bring these issues in. But for sure, it's not, as we thought, be a very technical problem. It's a much more complicated process. But I think that that's maybe what it takes to do cultural change. Maybe that's exactly where we're heading. So I think we're making good progress, but it will take a long time. What do you think, Stefan, about your hospital? Anything, because you have your comments, you have your colleagues doing the same thing, really?
It's the same discussion, but I would like to hear from you a little bit. What are you considering when it comes to methods for the work-based assessment? And how can it be done? What is feasible? What is reasonable? Not drawing too much resources, but still giving the information you want. Have you thought about that?
Oh yes, I mean this is a serious problem, because I mean in our case, what sort of came out after, I don't know what Jon actually did when you went to visit us, but what can be really, really sexy is the Mini CEX. That is definitely one of the instruments that becomes sort of oversubscribed, I would say. The DOPS, the Direct Appreciation of Clinical Procedures, seems to be slightly more complicated to take into work, but the Mini CEX, because the kind of question is asked and the generalizability of that instrument. The problem two, I would say. One, people are considered to be time-consuming. And when you count everything you do, and you have these productivity targets, almost like in a factory in the hospital, assessment takes time, when you have to fill out all these kind of instruments. So that's one thing. And the second thing is that what do I do with the instruments, and when do I take the time with my supervisor to discuss how I actually use these particular instruments. So I think that for us, Mini CEX is probably equal to the Karolinska University Hospital all over the hospital, but the way it's being implemented and the competition here between the productivity is a constant issue we're struggling with. All right, anything else you would like to ask at this point? Otherwise, thank you very much for attending. Yes? If I'm happy with the system. Look, I was in Burma recently, and I was actually teaching at the military academy for Defense Service and Medical Academy, and they were asking me a very political question, and that's perhaps not the place where you want to answer a political question. If I'm happy with the system, I think that as Stefan rightly pointed out, that there is no progression in the system. It's a very independent body, I would say. Even in our corridor at the hospital, we have the internship director, and we on the resident side, there's no communication whatsoever. So I think that, no, I'm not happy with the system because of the lack of progression, but I am happy with the momentum I think that we are up to when it comes to people becoming much more aware, both of the quality that needs to be into the national curriculum, but also that we have opened Pandora's box into the conversation about these things. But having said that, it's a different story from taking an instrument, just implementing it, to open Pandora's box, to start a serious conversation about assessment of various kinds. So I think we're making good progress, and if I'm happy or not, well, you know, we're making progress, but there are things to fix, and I'm glad for that. Otherwise, we would all be unemployed, I presume. Thank you very much for coming. And,
bueno, muchas gracias al doctor Jonas. Como vemos, pues las residencias no solamente son un problema en países latinoamericanos, también en países de primer mundo. ¿Sí? Muchas gracias, doctor.
Thank you very much.
Thank you so much.
Muchas gracias.
Gracias por su participación. Gracias.